All right, so today we're going to talk about child abuse. It's not the funnest topic to talk about, but it's kind of become one of my passions. I have, as he stated, I've worked in EMS for a long time, and I went into nursing and pediatric nursing mainly because I was kind of burnt out in EMS, and so I took a little time off from EMS, but I'm still actively involved teaching classes, etc. But I took this role about 4 years ago now, actually, and it really did a really good job of taking my love of pediatric patients and teaching, which I love, and then trauma, of course, that EMS, that adrenaline rush, et cetera, and kind of putting it together in a role. And so, as I just wanted to kind of explain, as a pediatric trauma coordinator, this is something that is kind of defined by the American College of Surgeons. When you hear level 1 trauma center, level 2 trauma center, if you're a pediatric trauma center, as we are at St. John's, we have to have a pediatric trauma coordinator. So that's my role. So I do a lot of making sure I'll go down, help out with the patients in the ER, but then I follow through with those patients from the EMS. I read run reports every day, all the way through to discharge, making sure that kids get the care, the resources that they need. And so it's really a fun job. I mean, even though it is trauma, it is fun with kids. So I ended up going back to school. I had gotten my master's in education, and I went back and I got my doctorate in nursing practice just actually this past fall. And when you do your doctorate of anything, really, you have to do a dissertation. And so I actually did my dissertation on child abuse. So I had to write this 100+ page paper on child abuse. So it's really become a passion. So I'm really glad that you tuned in to listen to me talk about this. As it is, something that I find very important. And I kind of think back to maybe some of the calls that I ran on over the years, realizing that maybe I should have done a little more for that child. So I'm just hoping that we can kind of spread the word. I'm using you guys as educators to be able to spread it to your students, and you're helping me get the message out there to more people than what I can do as well. So of course, this is going to give me a issue now. Okay, there we go. So objectives, we're going to talk about the definition of child abuse, the history of child abuse recognition, the prevalence of child abuse in the United States, risk factors, injury patterns that may suggest child abuse, describe the importance of documentation and mandated reporting of physical child abuse, and discuss ideas of how to enhance physical child abuse education in EMS. So I kind of answered this a little bit already. Why do I want to talk about this to whoever will listen to me? And it really boils down to a number of cases that I've had over probably the past. I've been a nurse now for almost 15 years. And working, in the PICU, unfortunately, I saw some cases, but even obviously now that I'm in this role, I see abuse a lot more than I ever expected it to happen, that I realized that it was happening. And in one case in particular, a few years ago, and I promise I won't do a lot of stories while I'm doing this lecture, but, we had this kid that came in and EMS ran on the child who had passed out. The boyfriend had taken the child to the mom's work, passed out. And there was just some red flags there. They didn't do anything wrong with the child, but they treated the patient. The patient was unresponsive, pale, cool. Well, she was awake, I'm sorry. She was complaining of abdominal pain, that her stomach hurt. And when they put her on the monitor or they checked her pulse was very tachy. She was extremely tachycardic. So in EMS education, we're really big on airway and we're big on cardiology. So they did what probably the majority of people would do, and they threw her on the cardiac monitor and they did a 12 lead because her heart rate was like 150, 160. And that's what we're taught, that, a kid's sick, their heart rate goes up. It could be SVT, so they really did everything they were supposed to. But when they brought the patient in, that's kind of how they presented it on the radio to that crew or to the hospital. So then when they got to the hospital, even the ER staff was thinking, okay, it's some sort of medical issue. And it wasn't until they took off the clothes and fully exposed this patient that they saw the bruising on this child. And at this point, she had gone unresponsive. And she actually had been stomped by the boyfriend. She had been severely abused. She had bruising on her abdomen. I'm guessing they probably put the 12 leads on underneath her shirt so that they, you know, to protect her privacy. And so anyway, she ended up dying. And it was a horrible, horrible case, one of the worst cases that, you know, my hospital had seen of child abuse. And there's nothing that the EMS would have done differently per se. It was just more of that recognition part of it. And so that kind of became my thought as myself as a paramedic instructor. Was I doing enough to teach EMS, my EMS paramedic students? Was I doing enough? So that's kind of what got me on this path and why I ended up going back to school and choosing that as my subject for my doctorate. So anyway, that's why I'm here today. So moving on. Hopefully if my slides decide to work today. So I'm going to keep talking. So I have, yeah, it's going faster than I am. Or slower than I am. Okay, so any recent act or failure to act on the part of a parent or caregiver, which results in death, serious physical or emotional harm, sexual abuse or exploitation, or any act or failure to act which presents an imminent risk of serious harm. And this is from the Child Abuse Prevention and Treatment Act of 2010. It was originally enacted in 1974. You know, I'm not going to do a lot of history on it, but it's just basically this mandates that all states have to have mandated reporters, which we all know that we are in EMS. So it just was amended and expanded upon in 2010. So this is the last quote I think I have. So but it remains that these cases are multiplying, that they provoke indignation, that they must not catch off guard the physician, often the only one capable of denouncing the crime to the legal authorities, and that they must not remain unknown to the forensic expert enjoined by the courts to explain its true character and to unveil all the circumstances of the deed. And I read this off and I use this quote a lot because if you look at it, this was from Tardot back in 1860. 1860, this French forensic pathologists realized that, you know, these kids weren't just walking down the street breaking their legs, because that's what the parents would say. I don't know what happened. And we still see that today. Parents like, nothing happened to the kid. There's been no trauma. No, I don't know how they broke their leg. It must have just broke. They must have just been goofing around. And so back in 1860, they realized that this was happening. So this is an ongoing problem and we're still fighting it. And so at this point, when he wrote this article, you know, he had identified 32 cases that he had identified as child abuse. So moving on as far as history, in 1946, John Caffey, a pediatric radiologist, described the association between multiple fractures and subdural hematomas or hemorrhaging in 6 infants. In 1953, Silverman, also a radiologist, stated that what may be called spontaneous fractures in a child are actually caused by trauma. 1962, C. Henry Kemp published the Battered Child Syndrome, and this is a very famous publication. And he also was the one who tirelessly wrote many articles on child abuse. And then in 74, Caffey actually described the whiplash shaken infant syndrome that we're so familiar with now. So kind of looking at the numbers to give you an idea, because I think what's important is that it's going to be very rare that you run on, or your students, they run on a patient that is so severely beaten that you're going to know right away, like, you know, that it definitely was abuse. What we have to be aware of when we're in EMS are those cases that, you know, when we get into it, we're going to see that bruising is a big, huge red flag for child abuse. So it's those little subtle signs that we really need to be looking at when we're taking care of these kids. And maybe we're treating them for something else, but we have to be on the lookout because we may be the only ones that get to see these children, especially if they don't plan on going to the hospital, if we don't recognize it. So in 2015, over 1,600 deaths from maltreatment. 75% of those deaths were in children under the age of 3. Can you imagine if if the public knew, oh yeah, 1,600 kids died because they were beaten. It's just not out there. It's not in the news. We hear about everything else, but we're not hearing about this, or it's so scattered that I don't think the big picture is there. Abusive head trauma accounts for about 1/3 of the deaths, although the number rises to 80% of the deaths in children less than 2 years old. So it's that shaken baby syndrome that's causing a lot of deaths in these kids. Physical child abuse is a common cause of TBI in infants. younger than 1 year of age. 25 to 30% of children with physical child abuse head trauma or abusive head trauma is another term. Only 15% of those will die with or will survive without any sequelae, meaning they won't have any long-term effects because of it. And the greatest risk of death is between the ages of 0 and 3 years old. And I do have to say, I like to talk to you while I'm presenting. I like to, kind of ask you guys questions, have you answer. So it is a little bit difficult to do that with this, but obviously I would ask you why are these, it's so young, why are these at the greatest risk? And of course, some of you would say, well, they can't talk, they can't necessarily say who did it. An infant can't say that, oh yeah, so and so shook me. So that's why you'll see a lot of, so the abuse also gets worse as it's repeated. It can happen one time, but it'll probably happen again, and it escalates in the severity of the abuse. A study showed that of 173 abused children, this is 54 were not recognized as being abused on initial presentation. So 15 were re-injured after the initial presentation, and 4 of those 15 died. So this is probably the biggest, once again, this is the biggest thing, is recognizing maybe those subtle injuries. I just use it. The subtle injuries, which are also called sentinel injuries. We have to recognize those. We have to realize that those are not normal, and we have to report those injuries. So we have to really be watching for those. Another study of about 1,500 patients showed that 53 of those patients had recurrent PCA, and there's an increased risk of mortality with recurrent PCA. Whether it's, they're getting angrier, whether it's they've already got some injury, especially to the, most of the deaths are going to be from brain injuries, whether it's, just compounding upon compounding with these patients. But the more they're abused, obviously their risk of being killed goes up quite a bit. All right, so risk factors for these kids. So males are more likely to sustain fractures. There is an inverse relationship to age and death, which we just talked about. African American children have a greater mortality from child abuse. Children that are born prematurely, children with multiple medical conditions, and poverty. And so, this is something to think about. And it sounds very bad, but for me, when I have a child come in with an injury, I basically assume they've been abused and I rule out child abuse. That's to the point where I've gotten. Do we have that many? No. But to me, I would rather make sure they haven't been abused than to not think about it. So I think about it on every patient, and I make sure that they weren't abused on their injury, making sure everything makes sense. All right, so perpetrator characteristics. And before I get into this, I need to stress very hard that this abuse happens at all socioeconomic levels. I don't care if you're white, black, I don't care if you're rich or poor, everybody, it's done to all children of all different kinds of homes. It doesn't matter. So you cannot use that as a, oh, well, they're rich, or, oh, look, they drive a Mercedes, or, oh, look at this big house. There's no way. That's not true. You can't let that cloud your judgment. I can't stress that enough. It happens in every social economic class. But some of the characteristics, and it makes sense. Younger parents, single parents, and I also feel like this is another good area when I'm teaching EMS, that I try and teach empathy. I know that that's one of those big areas that we really need to work on for EMS and all healthcare, actually. But trying to help the students or my coworkers or peers know that you have to think about these parents as well. A lot of times this isn't somebody that's a horrible person beating their child. Think about like a young person, maybe it's a couple, they got pregnant, they did not want that pregnancy. You figure you got a guy maybe that he wasn't planning on spending the rest of his life with this woman. The woman wasn't going to be with this guy for the rest of her life. Now they've got a kid, they're together for the next 18 years, whether they like it or not. Maybe they could barely take care of themselves. maybe they're not able to support themselves, and now they have a child, and having to navigate through social services, trying to figure out how they're going to live, how they're going to feed this child. It's a lot of stress. And that alone, when someone's stressed out, it can cause just that anger and, and immaturity. If they're young, they don't have that, um, just that maturity to stop, and hate saying it, but I do say it. My daughter knows I say it. But when I had my first daughter, she had colic. She was horrible. She was a horrible baby. She screamed every night. And I can remember looking at her and just honestly wanting to, like, that was my reaction and I can see it was the first time in my life I could see how it happened. And some of you may be thinking, oh, I'm a horrible parent, I'm a horrible person. But unless you've been in that situation where you have a child that's screaming nonstop for hours every single night, it's very hard to empathize with them. And so I try and stress that as well, that, but the difference was that I had that maturity. I was already 30, 31, something like that, in healthcare. I knew if I did that, I was going to hurt her. So I had the know-all to take her, put her in her crib, and then walk out of her room and keep myself from doing that. But if you are young and you aren't that mature yourself, or, all these other co-founding factors, you may not be able to stop yourself in the fit of rage. Lack of community support, depression, a history of depression or suicide attempts. If the parent was in foster care, maybe they've never really, there's really good foster care and there's really bad foster care, just like parents. I've talked about this already, whether it was an unplanned or planned pregnancy. Some of the other ones I don't think that's too surprising would be a history of criminal activity, decreased prenatal care, shorter birth intervals, so they're having kids one right after the other. Okay, I had 5 kids by the time, in a span of 5 or 6 years. I had twins. Right, it's not easy, but I also, had the resources I needed to take care of them. But if you're having a lot of children, um, it puts you at a risk factor. Increased number of separations from the child in the first year. We have lots of kids that come in and their father is incarcerated. The father's not involved in their life. Maybe mom had to go back to work. Maybe she had to go back before her 6 weeks is up. We don't have, a good maternity leave system. So if that kid is in daycare all the time and that bond is not being formed by the parents or even the caregivers, that's an increased risk. Obviously, alcohol or drug abuse. And then, of course, being abused as a child, it also puts them at risk. So as EMS educators, it's our responsibility to ensure that our students are comfortable assessing, documenting, and reporting cases of suspected child abuse. So the next part of this really goes into more detail. That's a little bit more what we'll be looking for, the treatment, the management, kind of some ideas of things we can do for these kids. But like I said, I'm really hoping that by you guys tuning in today, if you're not doing it already, you'll take a look at your child abuse section in the books and, maybe expand on it, maybe do a little bit more than maybe you've done in the past. We're really good at a lot of other things, the cardiology and the airway and, stroke. And I'm just implore you to maybe expand this section in the paramedic curriculum as well. So talking about some of the history red flags. So there's red flags that we talk about. There's like history, physical, and radiology red flags that we look at. And so some of the things, that as you're, whether it's yourself on the road working or as you're teaching your students, if there's a delay in seeking medical care greater than 24 hours, sometimes, yeah, they'll wait. Oh, I didn't think it was that bad. But sometimes they'll wait until it's too late and they're, now decompensating. It was an unwitnessed injury. They've got some sort of injury. The parents don't know how it happened. The explanation is inconsistent with the child's developmental and or developmental capabilities. So this is where that the childhood development portion of pediatrics comes into play. I think back when I started in EMS when I was 12, not really, when I was, 21, 20, I forget how old I was, 23. I didn't have children. I was very young. Luckily, I had a lot of experience babysitting growing up, but there are a lot of kids, especially today, that they're not babysitting. They may not have the siblings. Um, and honestly, I also say our EMTs, some of our new EMTs are becoming EMTs in high school. They're still kids, right? So they may not know all of those developmental milestones. So it may seem like a, skim over part in a book or something, but it is important because we have a lot of babies that are rolling off beds at 1 month old. Okay, babies don't roll off beds. Can they? Yeah. Or they roll off a changing table, or, because the parents who abuse the child don't know the developmental milestones of their own children. And so they're giving us stories that don't make sense. We had one where, this kid was old enough to tell us what happened. He was with his dad's girlfriend, and the dad's girlfriend said, oh, he hurt it. We went to the amusement park, and he was on the bumper cars, and he hurt his arm on the bumper cars. It was a humerus fracture. And luckily he went to an outside facility and was transferred to our facility. And it just makes me smile because this girl got burned so bad. On the transport over with EMS, the girlfriend obviously wasn't family, didn't ride with the child. And he told EMS in the back of the ambulance, I think he was like 5 or 6 or something, told them that no, the girlfriend had hurt his arm. And so threw her completely under the bus. And so they will tell you, but they may be scared, just like any domestic violence situation. They may just need the opportunity to tell you what happened. Different witnesses provide markedly different explanations for injury. We had a baby that came in and, not unresponsive, major head injury. And the parents, they just, nope, no trauma, no trauma. And then they started thinking about it after the child abuse physician came in to talk to them. Oh, wait, they'd ridden a bus all the way to New York and it was bumpy on the bus. So the kid must have hurt his head on the bus, just bouncing up and down on the bus that they took. And then they would change, when we said, no, that wouldn't have done it. And the story just kept changing. So they really struggled to come up with a story. And it's also important to point out that sometimes it's not that parent that's with the child. It could be a boyfriend, it could be the dad, it could be the mom, it could be somebody else, and they really don't know what happened. So it isn't just a easy thing to accuse someone of child abuse. You really have to do a lot of fact checking. Some more history red flags: they have chronic medical conditions. Okay, they require a lot of care at home by the caregiver. Caregiver can get burnt out, they're stressed out, maybe they're not getting support that they need. It just increases that child's risk. If they've been to the ED before, their prior ED visits, there's a history of domestic violence in the home, and of course, if you're referred for suspected child abuse. So these history red flags, these are all things, most of them that we can figure out in EMS and kind of, it doesn't mean that it is abuse, but it should raise your suspicion that it could be abuse. Physical red flags, and we'll go through these in a little bit more detail here in a second, but so you're doing a physical exam and they're a failure to thrive. So I look at our census every day and I look at the kids that have come in overnight and they're in the PICU or in the PICU or in the ER. And I look at every kid that comes in for failure to thrive. There's lots of kids, they may have pyloric stenosis or they may have something going on that they're not gaining weight. So they're admitted to the hospital. And it's legit probably 90% of the time, but there are times when failure to thrive. Is it because they're not being fed like they should be? Maybe it's as simple as someone's not mixing the formula correctly. Doesn't mean it's abuse, but it still needs to be looked at. So if you have a kid that looks extremely small for their age, that could be a warning sign. Bruising in a non-ambulatory child. And we're going to spend a lot of time with this. A torn frenulum. Okay, that's a picture there showing the torn frenulum in a child. The bruising, we're going to talk about, as I mentioned, the 10-4 faces, which, when I found this or started hearing about this, I'm like, why hasn't this been put into the EMS books? So hopefully this will start showing up because this is a great mnemonic. We have mnemonics for everything else. Bruises, burns, or scars in the shape of an object. And this is what we normally, teach our EMS. This is what's in the books. Yep, you'll see these shape, objects being hit by a belt or et cetera. So, that we kind of been trained on. So then some of the things, obviously, that we don't do in the field, but there are a lot of paramedics and EMT that do work in the hospital and maybe doing transfers. So rib fractures, huge red flag is rib fractures, especially in the infants. Fractures in non-ambulating infant. Do they happen? Absolutely, but I guarantee they're going to be worked up for child abuse. An undiagnosed healing fracture. Metaphyseal fractures and subdural hemorrhage, subarachnoid hemorrhage without a skull fracture and less than a year old. And like I said, we'll talk about some of these. So these are some of the things that, when they're doing x-rays, they'll or CTs, they'll find these injuries. All right, so common injuries. And so this one was kind of eye-opener for me when I really started getting into this subject, is the bruising. So normal versus abnormal locations of bruising. We've all seen those toddlers with bruises up and down their shins. That's normal. We expect that. Okay? But the age of the patient, infants shouldn't have bruises. There's really no reason for an infant to have bruising. Do they have any underlying injuries, especially under the age of 2? The shape and pattern of the bruising, the stages of healing, and that's the other thing we tell our students to look for. Is there multiple bruising, different varying stages of healing, different colors. And then, so we're used to seeing like accidental ones should be over the shins, the knees, the elbows, the forehead, right? Especially kids that are learning to walk, they fall, they whack their head on the floor, but they're usually hitting up here. Same thing, the shins are running into tables, they're falling, they hit their elbows. We expect to see bruises in certain locations. But if you see bruises on the cheek or the neck, the genitals, the buttocks and the back, that's not normal. And most likely not accidental. Bruising is very uncommon, as I mentioned, under the age of 6 months in children. So if you have an infant that you're running on, and you may be getting called for simple, they're not eating or they stop breathing. And that's another one of those kind of flags, is that apparent life-threatening event, or bruit is another term for it, the ALTEs, that you get called, oh, the patient's choking. Use that as an opportunity. Look at those kids, look for bruising. Those are some of those ideas that it may not just be what you're called for. And this is where I'm saying that you have a chance to look at these kids and possibly save them, honestly. As far as the benign abnormal bruising, there's Mongolian spots, mangiomas, even leukemia. They can have bruising. It's normal for them, or at least marks that look like bruising. And be aware that bruising can represent fractures as well, and that's for that underlying injuries, because sometimes the kids can't, if they've got a bruise, there could be a bone broken under there too. If they're young, they're not going to be able to tell you how bad it hurts. So the 10-4 faces P. So I've never been one for mnemonics, only because I can't remember them half the time, but this is one that I just absolutely love. This is where you should be looking for bruising in children for possible abuse. Doesn't mean it is, but it does. It really should raise a red flag. So the 10 stands for the torso, the ears, and the neck. So the torso, I just kind of say, think of a girl's bathing suit, a standard bathing suit of a girl, one-piece bathing suit. There shouldn't be bruising underneath that bathing suit. On the ears, you see that, and if you're not looking closely, they'll have bruising in here, from being pulled or having their ear yanked, or down here. On the neck, if you think about it, why would a kid have bruising on their neck? And the 4, and honestly, this used to be just 10-4. That's what this was, and they expanded onto it. So it's any kid less than 4 years of old that have bruising in these areas, because they can't really tell you what probably happened. Any bruising on a child less than 4 months, or greater than 4 bruises in the very young. And that's a new one I just added the other day, that I saw that someone's added that in now too, just the multiple bruising on a young child. Like a 2-year-old, yeah, I expect to see multiple bruisings, different stages of healing. That's just learning to walk and running into things. That's normal, right? But on an infant, I shouldn't be seeing multiple bruises all over their body. The F stands for frenulum. I showed the picture of that a little bit ago. The angle of the jaw, the cheek as well. We had one child abuse where they tried to say, well, it was because they were holding their face, and it may have been while they were burping the child, and it's very big possibility that's what it was. The eyelids, subconjunctival hemorrhage, and then the pattern bruises. So these are all areas we shouldn't be seeing the injuries. If they've got bloodshot eyes, bruising on their eyelids, just you might be sitting there going, well, that makes sense, Lisa, I know that, but are you teaching that? Have you run on any kids? Do you look at all your kids that closely when you're running on them? If you're running for a respiratory distress, or you're running for, vomiting or something like that, are you really checking those kids out? Or you kind of got blinders on for what we're being called for. And there's a saying in the trauma world, the pediatric trauma world, child abuse world, that says kids that don't cruise rarely bruise. Okay, so just kind of pointing out that, if they're not walking yet, they're not crawling, they shouldn't be having bruising. Okay, so once again, this is where EMS opportunity comes in. We have that chance. I go back to that 8-year-old that was stomped on and severely beaten by her mom's boyfriend. And, when EMS put that 12 lead on, they just weren't even thinking about it. But in reality, the patient was being taken care of by a non-relative. Most people, when a child goes unresponsive, you would call 911, right? You don't load them up into a car and drive them to the mom's restaurant where she's working to go get her to say, hey, your kid's unresponsive. So there's just those red flags. But if that's not something you were taught or something that you really, had spent a lot of time in, I don't expect people to know that. And so that's why I'm here. That's why I'm now trying to really stress this. These arm, the upper arm, why would a kid, that's being grabbed, and you can see the fingerprints on even the lower arm of that child, in the ear as well. So bruising is what they call a sentinel event, meaning that kids will be injured, they'll show bruises, and then the next time it may be something more. And I've got articles after articles here that show these kids that come back with serious injuries. They were already seen in the ER. They were already, someone had already seen these children, had identified that there was bruising, but didn't recognize it as a possible abuse. And then they come back and they have a more severe injury. So they're called sentinel injuries. They may not seem like much. They may not seem like they warrant an ambulance ride. You're like, oh, I'll just follow up or whatever. But this might be our chance to grab those kids and get them into the system and, get them going to get some help. Another one, burns. And honestly, I haven't seen a lot of these, thankfully. But a high percentage of childhood burns are due to abuse. So location of the burns is a big indicator whether or not it's going to be accidental or abuse. Accidental burns are usually in the head, the neck, anterior trunk, and arms. And I would say probably about 90% of our burn patients that come in are usually hot water, right? So they're getting a bowl of, honestly, it's bowl of noodles out of the microwave or off the stovetop. They bump into each other or they spill it, and the hot water pours on them, catches usually their chest area and their arms. Abuse, you're going to see it on the hands, the legs, the feet, and the buttocks, because they're, with this poor kid on the top, you can see that line of demarcation where the hands were held down. We'll get, they turned the hot water on and they got into the tub and got burned. Well, most kids, you get into a tub and the water's hot. Yeah, you might get in and you might feel that hot water, but the first thing you're going to do is try and scramble out, and you're going to see splash marks. You're going to not get as severely burned because you're getting out as fast as you possibly can. Someone is not going to be sitting in a bathtub going, oh, this water's hot. Oh, this water's hot, and not doing anything about it. That's where you see the more severe injuries. Holding the kid down in a hot bathtub of hot water. Sometimes they'll have that donut shaped ring around their buttocks because the bum actually sits on the cooler surface of the tub. So that may not be burned, but then you'll see the ring where they're actually making contact with water. So a lot more of the pattern burns. I did have a kid come in that did have like curling iron burns on his back. They weren't fresh, but they were old. They were scars. So I do take that back. I know I did see that kid. Pattern contact burns and the shape of the hot object. We talked about forced immersion. I just talked about, once again, that developmental level. Most kids, that's a instinct. That's just something, that's like your simple reflex, right? You learn that in biology class. You touch a hot stove, first thing you do is pull your finger away. You don't sit there and hold it and let it sizzle and get second, third degree burns on it. That's a, red flag there. Cigarette burns, people are still putting those cigarettes on the kids and burning their arms as punishment. And delay in seeking care. Sometimes the parents don't realize how big it is, and the burn will actually what we call blossom. We use that term a lot, like, bruises blossom, lung injuries blossom, they get worse over time. So anything like that, we're going to throw in a social work concern, or even, if it seems like a very small burn to you, but maybe it doesn't make sense. It's not a matter of just saying, all right, just cover up and let it go. You'll be fine. Really, they need to come in. They really need to get, that social work help. Bite marks, this is one I have not seen, honestly. Adult bite marks are typically indicated more sadistic abuser. And they say you may be able to swab the bite mark for DNA. But this, fortunately, is not something I don't think I've ever seen as a bite mark on a kid. So fractures are very common in abuse. And if you go back to, your pathophysiology of kids, you kind of learn that, the child's bones are not fully calcified when they're really young. And it takes a lot of impact to break a bone in a kid. It takes a lot of force, I should say. So that's why, if you're teaching pediatrics, or when I'm teaching pediatrics, I stress, just because your kid's in a car accident and you don't feel that crepitus that, we're taught to look for crepitus when we're feeling the chest, the kids probably won't have that crepitus because their bones are more pliable. They're not fully calcified. They're not going to crack as easily. But that energy, instead of being dissipated in the ribs, is being transmitted to the lungs, so they can have lung injuries. So to have a rib fracture in a small child and an infant, you can see the picture here of the hand squeezing that rib cage. It takes a lot of force to do that. And you do see that because they're holding that child and shaking the kid. And that's where you're seeing those rib fractures. And in infants, there's, statistics that say 80% of the time, those rib fractures are from abuse. If a kid's got a rib fracture and they're a baby, 80% of it's going to be from abuse. The posterior ribs are going to be the most commonly fractured. As you can see here, in that picture of the person hands along the rib cage there, you can see that the greatest force is imparted there at the articulation of the head and the neck of the rib with the transverse process. So you'll see that. You also see anterior lateral fractures, and they're going to be at multiple levels and bilateral. So you see here on the x-rays, you can see those healing rib fractures. And fractures under 18 months old are also should raise concern. So that's kind of that being so young. So any fractures of the humerus, unless they have a really good story, those spiral fractures, like from being their arm twisted, kids fall all the time. They get those elbow fractures, the supracondylar fractures. That's perfectly normal. But if you have a mid-shaft humerus fracture in a child, usually under the age of 3, that's a red flag for us. Okay, they'll probably get a social work consult unless there is a really good documented history of why that child hurt themselves and witnesses. Multiple fractures in various stages of healing as well. And so I'll talk about that in a second. So the fractures, spinal fractures, are usually associated with a head injury. Posterior rib fractures and fractures to the scapula, spinous process, and the sternum are indicative of abuse. So you can see a femur fracture there. Femur fractures, that just like an adult, they're hard to break in kids. There's no reason for a kid to have a femur fracture. I shouldn't say that, no reason. We did have one, I think they jumped off the bed or something and managed to snap their femur. But, you know, there's certain injuries, and you see that humerus fracture there. There's, you know, that's typical abuse fracture there. That's not your normal. They fall and their arm breaks. When they fall, it's usually down there at the distal humerus, is where that fracture is going to be. So the skeletal survey. So if you bring a child in for abuse, or you're working in an ER with abuse, they'll do what's called a skeletal survey. And so what this is it's usually anywhere from like 21 to 25 x-rays of the entire body. And I've got them listed there. I'm not going to go through, but they are taking a picture of different areas of the body. And it's usually under the age of 2. Anytime that we suspect that there could be a possibility of child abuse, we do a skeletal survey. And this is, you know, recommended. This is, you know, standard care, standard practice. So it's very high sensitivity for the most acute fractures, but also for healing fractures. So there's 2 ways we use a skeletal survey. We can take this skeletal survey, you know, and we'll do this if we've got a kid with a skull fracture, they're going to get they'll get a skeletal survey. If they've got any type of head bleed, they'll get a skeletal survey. So this skeletal survey will also show us any old healing fractures, because when you're reading a pediatric x-ray, it's very hard to find a new or acute fracture. So sometimes you will actually take x-rays and you will not see any fractures on those kids because it's so new. But maybe you will identify an old fracture that's healing, because you start to see, and if you remember on that other slide I showed you, you could kind of see the calcified area of where that rib was healing. And so that's what you actually end up seeing, is the healing part of the x-ray, or the ribs. I was trying to go back, but it's right there. So right here where the arrows are, you can see where that fracture, and it's starting to heal. And so you're starting to see that buildup of bone. So with the skeletal fractures, the kids often have to come back for another skeletal survey, called a follow-up skeletal survey, 2 weeks later. And so then we're looking for those fractures that maybe we couldn't see initially, but now we can see them because they're healing, and we're starting to see that bone being built back up. And that's when we identify it. So most kids, if we really think that there's abuse and we really think there's fractures there, but their first skeletal survey is negative, they'll be told they have to come back for a follow-up skeletal survey, and they will have to do that. There are some hospitals that do what's called a babygram, where they'll just sit the kid right there on the x-ray machine and take one big picture of the kid, one shot, and does not give good enough view. So babygrams are not the way to go. They're not recommended. So another common injury is abusive head injury, also known as shaken baby syndrome. They've changed it to AHT recently. So it's most common cause of death in children with NAT. So NAT, I thought I had changed all of these, but NAT stands for non-accidental trauma, if you're not aware. So a big population of, you know, especially in the trauma world, we started calling it NAT years ago. And then just in the past year, they decided to change and go back to physical child abuse, so that we stay consistent with other providers that take care of kids, you know, social work, etc. So you'll see both physical child abuse, non-accidental trauma. Same thing, you'll still hear shaken baby, even though other people are calling it abusive head trauma. So these are the ones, another kind of EMS call that come in, and there's no history of trauma. The parents like, no, nothing, there's, you know, they haven't hit their head, they haven't fallen, we haven't dropped them, etc. But maybe you're just getting called for vomiting. They're not eating right. They don't want to eat, and they're irritable, and they're just lethargic. And you get there and you really don't see any signs of trauma. You kind of believe them. Okay, yeah, okay. Why are you, you know, that jaded EMS view that, you know, why am I here if they're just fine, you know, take them to the doctor, right? We have a lot of these kids where EMS will recognize this. Actually, my husband just had one a couple months ago. He's a paramedic as well. Got there, dad's like, stop breathing. I was feeding him and just stop breathing. And, you know, and the kid was just really lethargic. ended up being shaken baby or abusive head trauma. So these are those calls that you've really got to stress to your students as well, that, it may seem like a simple medical condition, but it really could be indicative of something a lot more serious. And we see a lot of these kids come in, and that's, we have a pediatric clinic at our hospital, and we get a lot of kids that'll be brought over by the parents. Actually, the pediatricians realize that this isn't something simple. There's simple. There's something more to it, and they'll bring them in, and sure enough, they've got a head injury. And you can see here just, that coup contra coup mechanism of injury when you've got that shaken baby syndrome. So some of the injuries that you'll see with abusive head trauma, basically all your bleeds there, your epidural hemorrhages, your subdural hemorrhages, subarachnoid hemorrhages. Epidural, usually they have to have a direct force. So you're going to see probably a skull fracture with your epidural. Subdurals, not so much. So these, we see a lot of subdural hemorrhages with our shaken baby kids. And then also the subarachnoid hemorrhaging as well, as they're being shaken, you'll have that bleeding as the blood vessels are torn. The skull fractures, once again, though, with shaken baby, you're not going to have that skull fracture. So you may not see any outward signs of trauma. It's just how they're acting. Another injury that we'll see is diffuse axonal injury. And this is where you start to have shearing of the neurons because they're being stretched too far. Intraparenchymal hematomas, and then retinal hemorrhaging as well. And I realize this isn't something you'll see in the hospital, in the pre-hospital world, but I always like to know as much as I can about a subject. So retinal hemorrhaging is actually, if you hear about that, or you're transporting a kid that, has been shown to have retinal hemorrhaging, or maybe you're transporting them from one hospital to another so that they can have an ophthalmology exam. And the reason for this is because it's very rare to have retinal hemorrhaging without abuse, because it occurs in about 60 to 85% of non-accidental head injuries. So we actually will use this, they'll do the skeletal survey, maybe a head CT, and they get ophthalmology exams as well to look for retinal hemorrhaging. And this can be kind of that, that last little piece that we needed to go, yep, this is abuse. And you can see here, severe retinal hemorrhaging for diagnosis of child abuse had a 100% specificity in one study. So it's a really good way of checking whether or not it's child abuse, because this is from that shaking motion. All right, so the vessels are being damaged that way. You're not going to have that with just they just fell off the bed. That injury is not going to happen. You're not going to get retinal hemorrhaging from that. Encephalopathy, once again, this is just kind of different terms for, your level of consciousness, how your child's acting, and just, it's indicative of a brain injury of some sort. We don't have that radiology capability in EMS. So we have to go by our skills, by our assessment skills. So any of these can be a sign of severe head injury. You've got poor feeding, irritability, excessive crying or sleepiness, lethargy, periods of apnea, diminished reflexes, to seizures and comas. Exactly what we would see with any head injury patient. Just checking my time here. All right. So key points for us as educators is just maintaining that suspicion of child abuse, making sure that you're stressing to your students to keep that in the back of your mind. I think about some of the calls that I ran, like a child choking. There's one girl that was choking on Doritos. We got called for kid choking. And that almost every time you get on those calls that the kid's fine by the time you get there. Of course, I know there's cases that's not unfortunately the case, but majority of those. But this little girl, I remember, she was choking on a Dorito. She seemed perfectly okay, but she came running up to me and wanted me to hold her. I didn't transport her. She was fine. She was acting fine. But looking back, I'm like, why did this kid, little tiny 2-year-old or however old she was, come running to me to have me hold her? Meanwhile, why are you eating Doritos at whatever it was a crazy age that she was eating Doritos. And I think back, I'm like, what was going on in that house that she felt that she needed to run up to me? So really just make sure they're maintaining that suspicion of child abuse. Obviously, we know not to accuse anyone, but I just, like I said, it's just very important. Encourage transport even for minor injuries. You don't obviously have to say, hey, I think you've beaten your child. Let's get them into the hospital, get checked out. You can, we're all good at coming up for reasons. We do it all the time with our elderly patients or anybody else that we really know needs to go to the hospital. We know what it's like to try and talk someone into going to the hospital because for their own safety and their own health, they need to go. Doing that excellent patient assessment. If you have any gut feeling, any suspicion that something is wrong, even if it's not related to what you're there for, make sure you get a good patient assessment. Those paramedics that they had, undone, looked at that kid, did a really good, assessment of that. I shouldn't say a good assessment, but, had lifted her shirt up or moved her shirt, checked her stomach. She was complaining of abdominal pain. She had bruising, it was there. Make sure you're documenting all findings. Have your students write those reports out. Get a form. I will actually bring in in Michigan, it's called a 3200 form. And we practice writing them. I'll give them a scenario and they need to fill out the form themselves and write down and document the findings. And we all know, just keep it subjective, what you find, but documenting everything that you have, any type of minor injury, all the bruising. And I know people are busy, I know, but it really is important. At the college where I work at, when I still teach, I usually teach a special considerations class. So what I started probably about 4 or 5 years ago now, we do a special considerations seminar day because usually this is at the end of their course, or at least before they're getting ready to go, into the field. They're kind of getting to that burned out. They're done with medic class, etc. So instead of just doing a lecture during the day, we changed it to a seminar, and I would come in and do the child abuse lecture. I had Terry Godey, who speaks about human trafficking. She comes over and does a lecture on that, an hour lecture on that. And then, this sounds silly, but my mom's a social worker. And so she comes in and does a 1 hour lecture on geriatric abuse, another whole area topic that I have learned so much about from her. But so we actually would do like a 3-hour seminar where we would just focus on those topics. And it wasn't, it was just a different feeling of the day. We'd allow outside people to come in and listen to the lecture. So it wasn't like a classroom. It wasn't just a normal lecture day. It was something different, something special, and focusing on that, and really gave them the time to talk to other people that were, worked with these kind of cases. Using pediatric scenarios with symptoms and signs of abuse, trick them, right? We do all these, I'm doing a lecture and or a lecture for an expo coming up, EMS expo, and we learned so much about croup and epiglottitis and EMS, and we run those scenarios, and yeah, we've got those down pat. But what about doing a scenario where they're just called for a kid that's choking or a kid that's just not acting right, and not making it obvious that the kid's got abuse? And can they pick up on that? Do they realize that that's what's going on with the kid, or does it even cross their mind? And it might help guide your education in the future as well. So I think there's still a lot. I'm still trying to tweak what I do. I tweak everything every year. I'm sure you do too. As educators, we're always trying to improve our teaching and how we present our materials. So there's different things you can do, but I'm really hoping that we can kind of get this word out with these kids. And I think that's really all I have. I know it's a lot of information. I could spend a lot more time, as you can probably guess by how fast I was speaking, talking about this. But I really thank you for taking the time to listen today. And I hope you picked up a few things. That's usually my goal, is that at least learn a few things that you didn't know, even as educators, and incorporate it into your own teaching. So I think Nate is going to kind of do the question and answer. If there's any questions, he's going to kind of coordinate that for me.
Yes, absolutely. First of all, thank you very much for sharing all this information with us. I really appreciate you sitting down and talking about these topics. But one question that I was wondering if you could address. So at the very beginning of the presentation, you you made it very clear that it's something to consider is that these types of things are definitely possibilities at any socioeconomic level, and that they cannot be ruled out for any particular reason. But are you aware of any demographic patterns or any sort of things to look for when you maybe see a patient come in and their information, you know where they're from and sort of the short version of their background? Are there any um, patterns or tendencies that you're aware of that could help to guide people in where to look or certain signs to look for in particular based on that person, maybe their demographics?
Um, it's kind of, we've had cases, it's also how the parents act. A lot of it is, um, maybe they don't want anything being done to their child, or they're just in denial that anything's wrong with their child, or they won't leave the patient. Or if you have a caregiver that is very suspicious acting, or I want to say controlling over the other partner. That's just kind of, and you can kind of see that looking between the two of them. Like, I don't want to say the wrong thing, or they're trying to, the story's just not making sense. But as far as the social economic, I think I put that in, you know, I put in that, yes, it's a lot of single parents. It's, usually lower social economic class, but it doesn't mean that it can't happen. Um, you know, it does happen, and it's happened in my family. Um, and I guess my point is you can't rule it out. I'm trying to form my words here. So I think what I'm saying is that if you have somebody and you're like, have an injury, or there's bruising on this, cute little baby, and the parents just are just so beautiful and acting appropriately, seem to be okay, but the bruising and the injuries and everything doesn't look right, you can't just go, well, they're fine. There's no way they could do that. There's no way that he's a doctor, he couldn't do that. Or, she's a nurse, there's no way that this is happening. It does happen. Do I have a short list? No, unfortunately. I think, for me, I'm looking to see whether or not they were born prematurely. And that, a lot of that is because, one, they probably have health issues. So that's another one of those red flags. They also may have chronic, the medical conditions, but also that bonding's not there. If there's in the NICU for a long time, I worked the NICU for 9 years, and we have kids that are there from anywhere from a month up to, we had one that was there almost a year. Yeah, the parents come and visit, but you still don't have that bonding like you would. I mean, we do everything in our power, but not everybody can be there all the time. So I think that's where that prematurity comes into play. So it's more of just kind of looking at the overall picture, that prematurity, that chronic health conditions, the single parent, um, even just asking, I don't know what kind of support they have. It's very difficult. And I'll be honest, it's difficult. And, that's why at this point in my career, I've just like, everyone's being abused. And I know that sounds horrible, but, I want to rule it out versus rule it in. I don't know if that makes sense.
No, absolutely, absolutely, it does. Thank you very much. And we had a couple of questions that I think basically touch on the same thing. But as far as having these are incredibly difficult conversations that we're talking about having, and if and do you have any tips or any procedures that you follow for having for either parent questioning or how to have these conversations, or if you suspect any of these, that this may be a possibility? Is that something that you always want to forward on to the appropriate professionals, other people who?
Yeah. Um, Thank you for bringing that up, because that, honestly, before I really got involved in child abuse, my mom would come in. Sounds so funny, but because she worked in the hospital and that was her job. So she would come in and do that lecture for us, as far as filling out the 3200 form, the proper forms, our state form, abuse form. But it is important to make sure that you are telling the people that you are, the healthcare providers that you're bringing that patient into, they also need to file as well. You can't rely on one person to file. We've had instances, not at my current hospital, but at a different hospital, where I was told the doctors don't like to file individually because they don't want to go to court. They don't want to be named and brought into court for a case. So they won't file. And that also just knowing from, being in that social work field growing up, that the more reports that they get, unfortunately, at least in Michigan, they are overwhelmed. Our healthcare, our social services are overwhelmed. They receive so many referrals. They have to, I don't want to say pick and choose, but they really have to kind of pick and choose which cases they're going to open up based on their staffing and resources available. But if they're seeing one where you've got EMS and you have, um, the ER, you have, different, multiple, the fire department. I say the same thing to our local fire departments. File, don't rely on the next person to file because they may not. And the more reports that they get, it's going to build a stronger case for them to open up that case for the child, and look into it. So and the documentation, and you don't have to say, I mean, our ER is really good and they will tell the parents that we need to file a 3200 form. This is why. It doesn't, and they talk to the parents. Do I think that that's something the EMS should be doing in a home? Absolutely not. I think our safety is more important. I think it's appropriate to try and just, I don't want to say lie, but use, whatever means you can to get that kid brought into the hospital. Most parents, don't realize that, if they're calling you for something, they already think something's really wrong with their kid. So it's going to be a lot easier to take them to the hospital than try to convince them that their kid's fine and don't go to the hospital. So I think that is where, maybe you're going to a kid that was choking and you get there and they're not choking, and but you still are very suspicious. Okay, well, you know what? I really feel, I really think, well, let's get them in. We should probably get them checked out, make sure everything's okay. Kind of, and you kind of have to, I don't want to say lie, but you do have to kind of bend the truth a little why you want to get this child in. Because we do make mistakes. We can make those mistakes, but, I'd rather save one and make a couple mistakes, without, getting ourselves or putting ourselves in danger.